Okay, so basically now we are going to talk about the first stage of labor. We are going to discuss it. Okay. So basically this first stage of labor has two phases. The first one is known as the latent phase and the other one is known as the active phase. The latent phase is almost for about 3 to 8 hours and the active phase is almost 2 to 6 hours. Okay, this is to be remembered, 3 to 8 and 2 to 6. 3 to 8 and 2 to 6. Now, it is time from the diagnosis to the full dilation up to the 10 centimeter, and the first stage is divided into two phases. As I said before, that there is latent phase and there is active phase. Now, latent phase is from the onset of regular painful contractions till 3 to 4 centimeter, almost 4 centimeters dilatation of cervix. And why is it important? Because at 4 centimeter we plot the partogram. Okay, so at the end of the latent phase we start plotting, not before that, because it can be very long in some women. So that is why we plot after 4 centimeter dilatation. Now also there is effacement. Okay, and if there is no effacement and only dilatation, then this is an abnormality. This is known as cervical dystocia, and this leads to a delay in labor, and we are going to talk about it later. Now basically there is not only dilatation, there is also effacement. Effacement is very important in this process. The uterus, basically the cervix becomes shorter and it incorporates into the lower segment of the uterus. Okay, it becomes almost like its length becomes shortened. Now the process of effacement is may begin during the weeks preceding the onset of labor, but it will be complete by the end of the latent phase always. Okay, now these are the two things, effacement and dilatation. Now in nulliparous they occur at the same time, but in multiparous no, effacement occurs and then dilatation. They occur one by one in nulliparous, but in multiparous they occur at the same time simultaneously. Now dilatation is from 0 to 10 centimeter. Effacement can be expressed in percentage and it can be expressed in centimeter. And basically it is used in cervical length, and dilatation and effacement of these two things, dilatation and effacement, are used in Bishop's score along with other factors. Now, as I mentioned, the duration of latent phase is from 3 to 8 hours. Now the second phase. Now the second phase is known as the active phase, and it is of course from 4 centimeter onwards. Okay, so it is from 4 centimeter onwards. Now what happens in this phase is that there is full cervical dilatation up to 10 centimeter, and also basically cervical dilatation. What is the rate of dilatation? It should be 1 centimeter per hour, okay, or more, not less than 1 centimeter per hour. Okay, if it is less than 1 centimeter per 2 hours, then it is abnormal. So someone asks you, what is the cut off for abnormal progress of active phase of first stage? Then when you're going to say when cervical dilatation is less than 1 centimeter in 2 hours. You're not going to say less than 1 centimeter per hour. You're going to say less than 1 centimeter in 2 hours. Normal is 1 centimeter per hour and abnormal is less than 1 centimeter in 2 hours. Okay, so this was the first stage. Now we are going to have a look at the management of first stage and the abnormalities of first stage. So what happened in first stage? We're going to revise at the end. I just finished reading. Okay, so what happens in first stage? So how are you going to manage the first stage? Basically, it does not require any. There's a lot of glare. You do not. Just a second. Okay, so basically during the first stage of labor, it is the interval from diagnosis to the full dilatation we have already discussed. Now what do we need? Nothing. You don't need any active management. You need 4-hourly vaginal examination and partogram once the active phase has started after 4 centimeter dilatation of the cervix. And other than that, 1-to-1 midwifery care is needed. Okay, midwifery care is needed, emotional support is needed, and of course obstetric and anesthetic care. If she demands pain relief, then you will have to give it. And you also have to monitor well-being, as I mentioned earlier, that 4-hourly vaginal examination is needed and partogram is plotted once, not in the latent phase. Once more than 4 centimeters cervical dilatation has occurred, then you have to plot the partogram. And pain relief and adequate hydration and light diet. So mobilization and analgesia reassurance is needed. Okay, so mainly you also have to ask her to empty her bowel and bladder before at the time of the progress of labor. Now encouragement and reassurance is very important. So okay, so what was I saying? Yes, so basically what do you need? You need mobilization, analgesia and reassurance. These are the main things. Okay, you don't have to never rupture the membrane in the first stage, and never, unless there is a slow progression or arrest of progress. Otherwise, when there is normal progress, don't do anything. Just supportive measures and vaginal examination and partogram plotting. Okay, so mobility. Okay, The lower limit of normal progress is 1 centimeter dilatation every 2 hours, and when it is less than that, we are going to say that there is, slow progress. Now, descent of the presenting part is also occurring, and it is also assessed by vaginal examination. Now, during the first stage, membranes may intact or may rupture spontaneously. Now, if the membranes rupture spontaneously, it's okay, but don't you dare to actively rupture that membrane. Never do this mistake. Okay, this was practiced earlier when people used to manage first stage actively, but now in the guidelines that we use, never do that. Okay, either let them be intact, or if they are rupturing spontaneously, then let them be. Don't try to do anything yourself. Okay, now. You also have to record partogram, one-to-one care, same things are repeated. Choose birth partners, who are going to support them, and adopt whichever positions are possible. Standing upright encourages progress. Okay, instead of supine, ask her to stand upright. Okay. Now, basically, okay, you also have to give hydration and light nutrients, so that ketosis and dehydration is prevented, because if there's ketosis, it can impair contractility of the uterus. Light diet is acceptable. General anesthesia, pethidine or diamorphine. Basically, okay, light diet is also acceptable, and if she has had opioids, then she is going to vomit. So don't give her heavy food if she is on opioid. Okay, shaving and enemas are not necessary, and all of these things. Okay, now active management was, as I mentioned before, it was practiced earlier, but now it is not recommended. What did we used to do? Just for theoretical point of view, 1-to-1 midwifery, 2 hourly vaginal examination was done. Now we do 4 hourly, and artificial rupture of membrane was done. Now we don't do it, and use of oxytocin was done if progress was more than 2 hours behind the schedule of 1 centimeter dilatation per hour. Okay, now basically we don't use oxytocin unless in partogram the alert line has been crossed, and it has approached action line. Only then we use intervention, otherwise we don't. Okay, now we have discussed the normal first stage, we have discussed the management. Now we're going to discuss the abnormalities of the first stage of labor. Now, as I told you before, that there were two phases of the first stage. There was a latent phase and there was an active phase. Okay, now the latent phase was, as I mentioned before, was when up till 3 to 8 hours almost. And what happened was that up to 4 centimeter dilatation of cervix occurred and effacement occurred. Okay, two things, dilatation and effacement occurred. Now basically, let's say that this is prolonged. Why is it prolonged? When cervix is not prepared. What I mean is the cervical ripening has not occurred. When there is delayed ripening of cervix, then in that case there is prolonged latent phase. So excessive sedation, early epidural analgesia are also responsible for this. Now, these are the cause. So this is the main cause. Someone asks you, what is the cause of prolonged latent phase? Delayed cervical ripening. This is the only cause. Okay, delayed cervical ripening. Okay, because cervical processes are occurring. Now there is entirely only, we are only looking at the cervix. There is cervical dilatation and cervical effacement. So if it is prolonged, of course there is something wrong with the cervix. Cervix has not softened enough. It has not been prepared enough. Their cervical preparation occurs by the chemical procedures that we call as cervical ripening. So it has not occurred properly. Now what do? We don't do anything. We do mobilization and analgesia and reassurance. These are the things that we do only. Okay, nothing else. Mobilization, analgesia and reassurance. Now the next point is that the partogram is not commenced during this phase, only in active phase. So just do three things. Okay, so now we are going to talk about active stage. Now active was from 2 to 6 hours, and in that case cervical dilatation occurred until 10 centimeter, and also there was descent of the fetus also. Some descent also occurs. Now it has two types. It has primary arrest and it has secondary arrest. Now in primary arrest, what happens is that there is poor progress less than 2 centimeter per 4 hours, or you can also call it less than 1 centimeter per 2 hours. And it also more common in primary parents, because their uterus is not, it is undergoing such contractions for the first time. Okay, so inefficient uterine contractions are very normal in nulliparous females. Okay, but there can also be because of cephalopelvic disproportion, malposition or malpresentation. Now what is secondary arrest? Now primary arrest was when there was less than 2 centimeter per 4 hour rate of dilatation. Now what is secondary arrest? Secondary arrest is that initially progress is normal, but we have to remember the figure of 7 centimeter. After 7 centimeter dilatation, the progress stops or becomes slow. Okay, so this is secondary arrest. So in secondary arrest, you reach 7 centimeter dilatation normally in the active stage. Usually you are supposed to reach 10 centimeter, but in secondary rest you reach 7 centimeter normally, but after that progress slows down, less than 2 centimeter per 4 hours. Okay. Okay, now basically rest, and now this is it. So how are you going to manage this? Okay, so we are discussing the management of this poor progress of first stage. Now, as you all know that there are three P's. Okay, we have power, we have passages, and we have passenger. Now, now if the mostly in nulliparous women, as I have mentioned before, that they have ineffective uterine contraction. So in nulliparous women, the cause is ineffective uterine contraction. So most common cause is dysfunctional uterine activity in nulliparous women and in primigravida. Okay, no, not nulliparous, they have conceived, so we're going to call them primigravida, my bad. Okay, now you are supposed to assess uterine contractions, and you can use external uterine topography or any intrauterine pressure catheters, but we don't use them that much. So what is normal? Normal contractions are 4 to 5 contractions per 10 minutes. They are ideal, of mild to of almost of moderate strength. Okay, 4 to 5, but they are, this question is asked 4 to 5 per 10 minutes. Okay, 4 to 5 per 10 minutes. Now if this is if contractions are less, then in that case you are supposed to do more frequent examinations. Now let's talk about the algorithm. When poor progress is suspected, what do you do? The first thing that you do is that instead of 4 hourly examination that I had mentioned it before, you do 2 hourly examination. This is the first thing that you do in poor progress. Okay, what is the second thing that you do? Basically, after you have confirmed it, you do ARM. As I mentioned before, that in normal first stage, do not dare to rupture the membranes yourself unless they spontaneously rupture. But in this case, now as you can see that progress is slow, now you are going to rupture the membranes. Okay, artificial rupture membrane using amnicot. You can use an amnicot, or you can use a Cocker's forceps. Okay, now you are gonna wait for 2 hours. Now after 2 hours, if there's still poor progress, now you are going to give oxytocin to augment contractions. Okay, you did 2 hourly examination instead of 4 hourly, then you did ARM, then you waited for 2 hours, still no betterment, then you give oxytocin. Now oxytocin has some things that you must consider. With oxytocin, the contractions increase and there is a risk of uterine hyperstimulation, so make sure that the dose is normal, and you also give analgesia along with it. Always give it with analgesia, and increase them every 30 minutes. Okay, and according to well defined protocol. And you also need to do EF monitoring. Why? Because excessive uterine contractions are definitely going to EFM, not EMF. You are going to compress the cord, so electropheter monitoring needs to be done, epidural hydration, emotional support. Okay, these things are necessary with oxytocin, remember them. Now multiparous women, they are less likely to experience poor progress due to dysfunctional uterine activity, because in them the uterus already has experienced such contractions. So those lattice networks are ready to contract powerfully. So in multiparous women, if there is poor progress, there is some other cause. Okay, so in them, do not use oxytocin, it can lead to uterine rupture. Okay, first rule out other causes. Okay, so basically now after giving oxytocin, we give oxytocin, you are supposed to wait for 4 to 6 hours. Okay, and if nothing happens, no improvement, then you go for C-section. Okay, so this is the algorithm. Now what is the algorithm? Just a moment. Okay. So what is the algorithm? The algorithm is that the first thing that you do is that if there is poor progress in first stage due to power issue, poor uterine contraction. The first thing that you do is that you do 2 hourly examination instead of 4 hourly, and then you do artificial rupture of membrane, and then you wait for 2 hours. Okay, and then you give oxytocin. But with oxytocin, what are the important things? The first one is analgesia, and over 30 minutes you have to increase the dose, not before that. And you have to do continuous electropheter monitoring, and you have to give emotional support. All these things are necessary. And you have to make sure that you do not hyperstimulate the uterus until otherwise uterine rupture can occur. Okay, normal are 4-5 contractions per 10 minutes, but what is uterine hyperstimulation? It is more than 5 contractions per 10 minutes. Strong contraction, this occurs because of excess oxytocin, so be careful. Okay, otherwise a new issue will arise and you will have to manage the uterus, then the uterine rupture then. there will be a lot of problems. So make sure that you raise the dose slowly and do not overstimulate the uterus. Now you are going to wait for 4 to 6 hours, still no improvement, then you're going to go for a C-section. Okay, so this is how you're going to manage the power issue, the uterine contraction issue. Now basically next thing is the second P is passages, and then you have passenger. Now there can be cephalopelvic disproportion, there can be small pelvis, there can be short stature less than 1.6 meters, there can be a previous fracture or metabolic bone disease, a fetal anomaly can be there, obstructive hydrocephalus can be there, macrocephaly, so the head won't pass, and fetal thyroid and neck tumors may also be there. Now relative cephalopelvic disproportion is more common and it occurs when there is malposition. Now what is relative cephalopelvic disproportion? When the size of the head is normal but the position is wrong, there is malposition. Okay, and such as occipito-posterior normal, we need occipito-anterior position, such as occipito-posterior position and occipito-posterior position, the head deflexes. Actually we need full flexion of head, but now opposite is happening, the head is deflexing, and now the larger skull diameter is going to present. I think in occipito-posterior we have I think we have which diameter presents, yeah, in, yeah, basically we have occipitofrontal diameter. Usually we need sub occipitobregmatic diameter in a well flexed head 9.5 centimeter. This is the best, but when there is deflection, then occipitofrontal diameter, which is 11.5 centimeter, and it is no OP, it is very large. And then we have, if there is neutral neck or extended neck, there is brow presentation, there is occipitomental, absolutely cannot pass, 13 centimeter cannot pass, because the transverse diameter is of inlet is up till 11 centimeter. And hyperextended face presentation is 9.5, this can pass, but face can be damaged, and submentobregmatic diameter is over here. Okay, so 9.5 centimeter measurement, we have two diameters, sub occipito and sub mento. Sub occipito is the best with a well flexed head, and sub mento bregmatic can also pass with a face presentation, but it is a bit risky. And with with OP position, we have a deflex head and we have occipitofrontal diameter, which is 11.5 centimeter. Okay, so where were we? Yeah, so this is about the passages and passenger. We are talking oxytocin. Okay, if there is obstructed labor because of cephalopelvic disproportion and you give oxytocin, you don't need oxytocin now, because contraction is fine. The problem is with the passageway, and so what is going to happen? Uterine hyperstimulation and rupture. So be careful. Okay, but if there is mild to moderate cephalopelvic disproportion, you can give some oxytocin, but be careful and monitor the CTG. Now relative disproportion is overcome if you correct the malposition, so you can and oxytocin must never be used, okay, when there is cephalopelvic disproportion in the multiparous woman. Okay, so how are you going to know that there is cephalopelvic disproportion? Fetal head will not be engaged on examination, station 0 and positive will not be reached, and progress will slow. Uterine contractions will be good and normal, but still progress will be slow, still poor progress. Then you will think that okay, now this is due to CPD, and there can be molding. What is molding? Basically the skull bones, they come together. When they slightly touch each other, this is known as grade 1. When they slightly overlap each other and reverse, this is known as grade 2. And when they basically totally overlap each other and are unable to get back into original position, then that is called as stage grade 3. And grade 3 is very dangerous. So what is grade 1? Bones touching each other, not overlapping. What is grade 2? Overlapping but easily separated. And what is grade 3? Fixed overlapping and occurs in cephalopelvic disproportion. So grade 3 is very dangerous. Okay, it can lead to cephalohematoma and altered skull, and it is molding is usually grade 1 and 2 is almost normal. Okay, alteration in the shape of fetal head during passage through resistant birth canal disappears within few hours of birth. Okay, now basically, and if there is hematuria, why will there be hematuria? Because of bleeding, and any trauma to the baby will cause hematuria in the mother. So when there is no engagement, and when there is no engagement, head is not being engaged, head is severely molded, there is cephalohematoma, and there is or caput succedaneum is being formed, and hematuria, and so the two things with the head, okay, not engaged and severely molded. Always remember grade 3. And also one thing with the progress, that progress will be slow despite adequate contraction. Now something wrong with the passenger. What can be wrong? So basically we know that firm application is needed of the fetal presenting part onto the cervix. What is the presenting part? That portion which is overlying the cervical os. If cervical os is not being pressed by that presenting part, then progress will not occur. So face an occiput. Occiput is, very firm and hard, and it presses very adequately. So occiput to anterior position is very good, but face presentation does not lead to, adequate force on the cervix. So it is, can lead to poor progress. And bro presentation has, what diameter it had? It has mentovertical diameter, which is totally, or occipitomental diameter, which is totally more, which is 13 centimeter. Totally, it's impossible for this diameter to pass. Okay. And shoulder presentation can also not deliver vaginally, and malpresentation are more common in women who have high parity. Why? Because their uterus is more lax and there's more space for the uterus, so the fetus turns and takes a position of its choice. Okay, so there can also be something wrong with the passage with the birth canal. There can be fibroid, cervical dystocia. What was cervical dystocia? As I discussed in the first stage of labor, that the cervix is dilating, but the cervix is not effacing. So what are you going to do with a dilated cervix? Is there is no effacement, it is useless. You need both things. You need dilation and effacement. So if there is no effacement, this is known as cervical dystocia. Okay. And effaces but fails to dilate. And severe, why does it happen? Because of severe scarring or rigidity. If the female has undergone previous cervical surgery due to cervical carcinoma or cervical dysplasia, not cervical dysplasia, cervical intraepithelial neoplasia, cone biopsy. So in this case, you'll have to do C-section. So this is it about the first stage of labor.